Genomics and precision oncology. This is what we will learn in the presentation today. Why does cancer happen? The root cause is in the DNA. Hence, we need to study the DNA, and we can study it by sequencing, by reading what are the codons in it. If we know the sequence in the DNA, it has clinical implication. And this graph demonstrates that. Group A is treating patients based on the genetic mutation. For example, there was an EGFR mutation, we gave EGFR therapy. They had better outcomes, better survival than those who were not given genome guided treatment at all, that is group C, or who were given in the later lines. Therefore, picking up the driver mutation in the frontline setting matters because it improves survival. There are four main genetic alterations driving tumor growth. Number one is base substitution. Classical example is a BRAF V600E. The second variety is insertion and deletion. Exon 19 deletion EGFR, the classical example. Number three is copy number alterations. For example, a HER2 amplification. And then rearrangements are fusions. The typical example is an ALK fusion. These are the four classes of genomic alterations. Now, how can you sequence? How can you read the codons on the DNA? How can you read the nucleotides in the DNA or an RNA? Well, if I do a normal sequencing, I keep reading linearly, okay, by a Sanger sequencing. The length of DNA in a cell is almost 2 meters that contains 6 million nucleotides. If I do by Sanger's, which is also called first generation sequencing, if I have to see the whole genome, it will take nearly 60 years for an individual. Therefore, then came what is known as the second generation sequencing, also called the next generation sequencing. And the third generation is nothing but an NGS without amplification process involved. I will explain in the future slide. Okay. Can anyone figure out how many mistakes are there in the paragraph? So if you read in the first line itself, DNA sequencing with commercially available. So B is a mistake. Instead of A, there is B. Similarly, if you go through, there are multiple mistakes in this. If I read through, I will take almost 1.5 to 2 minutes to fix it. Okay, this is what we do in Sanger's. In Sanger's, we read through each line. This is called sequencing. Okay, what do we do in NGS? In NGS, we cut each line. Okay, and we amplify each line and give it to other people to read. This is called as massive parallel sequencing. That is, I cut each line and I give it to each individual so that each individual reads it multiple times and fixes the problem. This is called as massive parallel sequencing. So this is the steps that you saw in NGS. You would cut the DNA fragments and then you will amplify it and then you will read each one multiple times to make sure there are no errors in it. This is called NGS. So imagine one single guy reading the whole paragraph, how much time it takes versus dividing paragraph to multiple lines and multiple parts and asking different individuals to read simultaneously. This is called massive parallel sequencing, and therefore NGS is faster than Sanger's. Right? The classical definition of NGS must include both of these. Massive parallel sequence. Okay? Concurrently, it reads out each sequence, each fragment. And then high throughput process because it is done concurrently. Not that I'm reading through and through the paragraph. Instead, I am splitting a paragraph into multiple lines, and each line is read simultaneously, concurrently. A massive parallel sequencing is happening. That is why NGS is quick and more accurate. What are the types of gene sequencing? So, single marker sequence, that is, you know that I want to see this particular mutation. I will see that. I want to see whether there is a ALK mutation or not. I look only at a known mutation. This is called single marker sequential. The other one is hotspot NGS. That is, I will look into only those spots where a mutation is possible to happen. And the third one is a CGP, or a comprehensive genomic profiling, where I see comprehensively the whole genome, I mean, which are usually implicated in cancer. So this is a pictorial representation of a single marker testing. I want to look at ALK. I look at ALK. I do not look into any other mutation. That too in the ALK, I look into a particular domain only. I look at only rearrangement. I do not look into substitutions, insertion, deletion in ALK. I look at only a rearrangement in ALK. This is single marker. Then coming on to hotspot testing or a hotspot NGS. I look into hotspots, specific parts of EGFR, RAS, BRAF, ALK, ERBB2, MET, and so on. But I do not look into the entire genome. Then comes the CGP, Comprehensive Genomic Profiling. I look into all the top genes implicated in cancer. I not only look at substitutions, insertion, deletion, rearrangement, or copy number variations. I look into all the types of mutations in all the top cancer genes. This is called comprehensive genomic profiling. So you figured out the difference between a single gene or a single marker assay or a hotspot assay or a hotspot NGS or a comprehensive genomic profiling. To just differentiate between a hotspot NGS and a comprehensive genomic profiling, a hotspot NGS specifically looks at base substitution and insertion deletion. But picking up a copy number alteration or a gene fusion or a TMB or an MSI is not in the domain of hotspot NGS. But a CGP can pick up all types of genomic alterations, base substitution, insertion, deletion, copy number alterations, gene fusions. Along with that, a TMB and an MSI can be picked up by a CGP. Right. What is the advantage of a CGP over the other? Either a single gene or a hotspot. There is a 17% more chance of picking up an exon 19 EGFR, 22% more chance picking up a EGFR point mutation like an L858R, 15% more chance of HER2, 26% more chance of NCCN genes versus hotspot, and 35% more chance of ALK fusion versus a fish. So therefore, not that I find uncommon mutations, but also find common mutations at a greater frequency. This is the typical example is exon 20 insertion. If I am doing a PCR based testing, 50% chance that I will miss an exon 20 insertion. If I do a CGP, there is a double possibility of picking up a exon 20 insertion. Okay, CGP not only can capture common mutations at a higher accuracy, but also can pick up co-mutations. For example, you have what is called a KSC mutation. These are all RAS G12C mutated lung cancer patients. In these patients, if I have KSC genes mutated, for example, a KEAP1 SMARC4 and a CDKN2A, If these three are mutated, they do poorly. The upper one, graph says, if all three are wild, KRAS does better. If they are mutated, it does poorly. Therefore, knowing a concomitant mutation is important. So, what is the learning point? Number one of what we discussed till now. CGP is superior to hotspot NGS and Sanger sequencing when it comes to detecting a higher likelihood of common mutations, uncommon mutations, and coexisting mutations. Right. Now, let's go to whether should we do a single gene test first. That is, I will do an EGFR by PCR, ALK by IHC fish, and then if I'm not able to find the mutation, I will send it for NGS or a CGP, or I will do a CGP upfront. The advantage of doing the CGP first is the tissue availability. Okay, if I am doing a single gene test first of all, if I have the left part shows the amount of tissue in the paraffin block. From the paraffin block, I will make slides. I will need at least 10 slides for histopathology and immunohistochemistry. The next step is I will do a single gene test. For that, I need 35 slides. And you can see the tissue reducing sequentially. And then if I do not get a result, I will go to the CGP. And you can see the amount of tissue left behind, minimal. So I end up with shortage of tissue, not able to perform CGP in a lot of patients. Then coming on to CGP first strategy. If I do a CGP first strategy, I will need only 10 slides for diagnosis, that is histopathology and immunohistochemistry, but the remaining tissue is adequate for performing a CGP. Therefore, a CGP first strategy is where I will have adequate tissue available, and this is reflected in this particular study. If I do a SGT, single gene test, and then CGP versus CGP alone, there is a significantly higher chance of picking up a target mutation. Therefore, the way to go is not to waste tissue by single gene testing, but to straight away go for a CGP. Right. Let us have a case history demonstrating CGP. This is a 68-year-old gentleman, never smoker, diagnosed with an advanced lung cancer with a TTF1 positivity, therefore it's adenocarcinoma with a PDL1 TPS of 10%. The patient had pleural effusion, therefore it is fourth stage. The tissue 12 gene panel NGS was sent to a local lab, hotspot NGS. And you can see either a RNA variant or a DNA variation, no mutations were detected. What did they look at? They looked at fusions in the RNA, ALK, ROS, RET, NTRK, and they looked at the, the single nucleotide variation and insertion deletions in the rest. None of them were detected. So the patient, by rule, without a target mutation, should receive with a positive PDL1 should receive a chemoimmunotherapy. This patient received PEM carbo pembro. Post 2 cycles, instead of having a response, developed cross disease progression. A liquid biopsy by a CGP was sent. It revealed an EGFR L858R, which is a point mutation, which we missed in a hotspot NGS. As you heard, around 25% chance of picking up these mutations when I do a CGP. So after having picked it up, started patient on osimertinib, excellent response at 3 months, and you can see the images, how well the patient has responded. So very important to a CGP to pick up a higher chance of a driver mutation and to not lose the opportunity. Do it in the upfront setting. Doing it later on, you may not be able to offer the patient may not live for that. Now comes tissue is an issue. Okay, the biopsy, and if I have to send the blocks for CGP, there is a 40% chance that the tissue is inadequate. This is based on the data. This is the left is our expectation for the tissue adequacy, but in the right is the reality. You hardly have any tissue left. The solution is liquid biopsy. This is Penn2 studies that is stating that 44% patients with tissue for all the 12 genes, NCC and targetable genes, 44% chance the tissue was inadequate. Therefore, a liquid biopsy will be helpful because it is quick and there is good concurrence. Non-invasive, liquid biopsy is non-invasive, can do it repeatedly, it is representative, it overcomes heterogeneity, and it is quicker. This is liquid biopsy in one slide. What do I see in liquid biopsy? I see the cell-free DNA. And then either you can do only liquid or you can do liquid plus tissue. You can do sequential, plasma first. All these approaches are acceptable. It is minimally invasive and very important is it has an excellent sensitivity of 70 to 80%, but specificity is nearly 100%. But it cannot find out PDL1 or the histology. So is liquid biopsy as good as tissue? Answer is yes. This is the study. This is called as a Nile study. Nile is non-invasive versus invasive lung cancer evaluation. Just look into the two circles. Tissue is the blue circle and liquid is the red circle. You can see that 48 patients had both tissue and liquid positivity. 12 patients had only tissue and 29 patients had only liquid. In fact, liquid had a greater probability of picking up. But however, if I do both, that is the best possibility of picking. If I do tissue, there are some mutations which I miss in liquid. Uh, and if I do liquid, there are some mutations that I miss in tissue. Therefore, doing both of them at the same time is the best way to go. So, altering tissue, liquid, CGP together is the most efficient way to capture all targetable mutations. So, liquid equals tissue. There is excellent concordance in lung, colorectal, biliary tract cancer, and also in breast cancer. Okay, 90% and above concordance, and this is NCCN saying that if you can do concurrent plus tissue approach, it is recommended. So learning point number 2, tissue samples are inadequate in around 40% of patients for all the targetable mutations. Liquid biopsy, there is a strong concordance with tissue. If I can do both tissue plus liquid together, it is better and faster. Now let's see how we can apply the liquid biopsy in metastatic colorectal cancer. Okay, the concept of hyper-selection, EGFR rechallenge, and neo-RAS. There we go. We all know that colon cancer, colorectal cancer, you want KRAS, NRAS, BRAF to be removed because they are not fit for anti-EGFR therapy. If I am doing KRAS, NRAS, BRAF by just sequencing, I am missing out 25% of patients who are actually mutated because 25% of mutations are there in the domain that is not covered by the hotspot testing. Therefore, if I am giving anti-EGFR therapy based on the hotspot testing, I am over treating 25% of patients who would not benefit with an anti-EGFR. Therefore, I would not benefit these patients. However, if I do a negative hyperselection, that is, I would actually pick up the true uh, RAS, RAF wild type population. This is called negative hyperselection. If I do an extended CGP and pick these patients up, this is called the paradigm trial. Okay, there's an extrapolated study, exploratory biomarker analysis paradigm trial. We all feel that For left-sided, it is anti-EGFR and wild type, and right-sided, it is bevacizumab. But look at the curves. Whether it is left side or right side, if I can negatively hyper-select this population, okay, by wild type, okay, I did a CGP and took out all the mutated population. If I negatively hyper-selected, anti-EGFR works better irrespective of left or right. Therefore, the take-home message is, if I can do a CGP and find out that extra 25% patients who are actually RAS mutated, then the sidedness is not a great predictor. It is the negative hyperselection that is the predictor. This is about hyperselection. Now, re-challenge. Let's take an example of a 61-year-old gentleman with a stage 4 metastatic colorectal cancer with lung and peritoneal mets. He is ALRAS BRAF wild type. This patient underwent FOLFOX panitumumab for 8 months, and then patient progressed. We did a liquid biopsy. The previous RAS wild type now has become RAS mutant. This is an acquired RAS mutation positive. Now, because there is progression, we changed to FOLFIRI plus bevacizumab, and then the patient progressed in 5 months. Okay, remember, RAS mutations are dynamic. The baseline wild can become mutant, and again the mutant can decay. This is called as the RAS mutant decay time. By around 4 to 5 months, they decay out. And we did a rebiopsy. Now there is no RAS mutation. Now in these patients, if we re-challenge with panitumumab, again there is a good partial response. This is the slide. Initial RAS wild type, we gave anti-EGFR, RAS mutant came up, okay, and then we gave bevacizumab. Again, the RAS mutant went away. We again have RAS wild type. Again, you give re-challenge with anti-EGFR. So this is the Chronos study demonstrating the practicality of anti-EGFR re-challenge in the third line. Okay, anti-EGFR chemo first line. You got RAS mutant clones. We give VEGF or EGFR free treatment, and then you did a liquid biopsy. You found there is no RAS mutation, and you gave re-challenge with panitumumab, and you will end up, if I do a liquid biopsy, I will be taking out 30% of patients who continue to have mutation. And if I can give in RAS wild type patients anti-EGFR in the third line, I'll be able to give an overall survival of 13 months. Okay, if you remember regorafenib, it gives OS of 6 months, almost doubling of overall survival if I can select out patients who are RAS wild type on a liquid biopsy. Okay, so liquid biopsy equals tissue biopsy at progression. First line in the front line colorectal, tissue is the way to go. Later lines at progression, liquid biopsy is the way to go. Okay, if I do a tissue, it is inferior, 76% for liquid and 48% for tissue. Okay, now coming on to what is called as the Godzilla study, neo-RAS. What it means? Initially, patient had a RAS mutation in the tissue. We gave, let's say, FOLFOX wave, and then we looked in a liquid biopsy and we looked whether the RAS mutation is persisting. No, it became wild type. This RAS mutation becoming RAS wild type, the possibility is 19%, especially if there are no liver mets and lymph node metastasis, and RAS KRAS exon 2 mutation should not be there. In these situations, if I can see, there is a 19% possibility of having a RAS wild type in a known RAS mutant population. So the clinical outcomes, if I can select out these neo-RAS patients, I do a liquid biopsy, I found RAS wild type, if I give anti-EGFR, excellent progression-free survival. Therefore, the concept that once RAS mutant in a tissue is RAS mutant ever is not correct based on the Godzilla study. You can pick up neo-RAS patients. That means those patients who are not not KRAS exon 2, do not have liver or lymph node mets. In those patients, if I can give, I have picked up RAS mutation initially, and I've given some, let's say, full fox BAVE, and then at progression in liquid biopsy, they turn out to be RAS wild type. They're called neo-RAS patients, and if I can give EGFR in them, they have an excellent progression-free survival. Learning point number 3. Negative hyperselection is a better predictor for anti-EGFR efficacy than tumor-sidedness. Decay of acquired RAS mutations detected by liquid biopsy predicts anti-EGFR response in third-line metastatic colorectal cancer. New RAS mutations found liquid biopsy may qualify for anti-EGFR therapy. Now, quickly going on to the biomarkers for immunotherapy. 3 important biomarkers we have, and then let's see the different platform, tumor mutation burden, and what is the overlap. These are the 3 important biomarkers for immunotherapy: PDL1, MSI, and tumor mutation burden. These are the different platforms. 22C3 for Pembro, 263 for Atizo Durva, 142 for Atizo, and 288 DACO for Nivolumab. This is the definition of TPS and CPS. TPS is tumor proportion score, number of positive tumor cells. For PDL1, the denominator is total number of viable cells, whereas CPS is both tumor cells and immune cells divided by the number of viable cells. Therefore, CPS is always greater than the TPS. So these are the different platforms. This is the blueprint to study. What it says, we saw different platforms: 22C3, 263, 288, and 142. Very important is 22C3, 263, and 288 are concordant, whereas 142 is not concordant. So that is important. Blueprint says SP 142, 263, and 22C3 are concordant, and SP 142 is not concordant. Okay, now coming on to tumor mutation burden. The cutoff of tumor mutation burden is more than or equal to 10 mutations per megabase. It has high response to immune checkpoint inhibitor. Remember, there is an inherent TMB. For example, in a melanoma or a small cell lung cancer, there is an inherently high TMB. In the right corner, you can see. In the left corner, you have pediatric tumors like a rhabdoid tumor or Ewing sarcoma. They are not immunosensitive. Therefore, you would see none of the pediatric tumors are immunosensitive. This is why a high tumor mutation burden attracts a lot of immune cells. There are a lot of antigens exposed on itself, therefore it attracts a lot of cells. High TMB, high neoantigen, immune cells are attracted, therefore it is immunosensitive. Now, if I say if the patient is PDL1 positive, he is likely high TMB, likely high MSI. No, it rarely happens. There is rarely an overlap between these PDL1, TMB, or MSI, these immunotherapy biomarkers. So therefore, we shouldn't be having a feeling that a high PDL1 is high TMB. Doesn't happen usually. Okay, learning point number 4. There is good concordance among 22C3, 263, and 288, but not with SP142. TMB of 10 is the cutoff. The 3 immunotherapy biomarkers, PDL1, MSI, and TMB, rarely overlap. Okay, role of MRD in colon cancer. Right, we all know there is an issue with stage 2 and stage 3 disease. This is where we give adjuvant therapy, but how much adjuvant therapy we want to give is a question. Okay, for stage 2, that is T3N0, M0, we look at those high risk factors like in LVI, PNE, was there a perforation, is there inadequate lymph node dissection, MSI, and so on. They're called clinical risk factors, clinical pathologic risk factors. So therefore, the options are observation, capecitabine, FOLFOX, Kpox, 3 or 6 months. All this is confusing. Therefore, how much amount of adjuvant therapy and what we need to give is subjective and is based on clinico-pathological criteria. Is there an objective way of doing it? The answer is yes. That is by assessing the minimal residual disease. What is minimal residual disease? It's a very small number of cancer cells that remain in the body during or after treatment. Highly sensitive test. It should detect 1 in 1 million cells. CEA is also a type of MRD, but problem is it is either specific or sensitive. Its sensitivity is something like 37% in stage 2 and 46% in stage 3. And it is not specific. It can be raised due to multiple reasons. Due to any bowel problem, any substance issue, or any lung issue, it can be raised. Therefore, it is either sensitive or specific. So this is how an MRD is depicted. By scan, I find that is a gross disease. I do not find by scan, but I find by a blood. That is called minimal residual disease. Okay. The detectable circulating tumor DNA is MRD positive. That is not detectable is is basically undetectable MRD. But undetectable MRD usually is taken care by immunity itself. So no need to worry for that. So a detectable ctDNA is where you need to act upon. This is called MRD. This is the slide saying that the left corner green is ctDNA. The right, but the the brown one is all the clinicopathological risk factors. If I can combine both of them, I have the highest predictive accuracy. This is the dynamic study. Post surgery, stage 2 colon. You classified the patients, okay, those who are ctDNA positive or negative. One arm underwent ctDNA under management, other arm went standard management. By those who are ctDNA positive, only ones who gave adjuvant chemo. So they looked, what was that they could find? They could find that if I can treat by ctDNA based treatment, I can treat less number of patients. Almost half less treatment can like 15% versus 28%. So half less de-escalation could happen on almost 40% patients. And even if I'm treating less, recurrence-free survival is non-inferior. This is the dynamic study. What it says, adjuvant chemotherapy usage is less. If I follow it, the 2-year recurrence-free survival is similar in spite of de-escalation. Therefore, ctDNA-based treatment should be the way to go, where I will be able to reduce treatment without affecting outcome. This is the Pegasus study. Again, saying that the left one is the prognostication based on the stages. Stage 2, stage 3 low risk, stage 3 high risk. You can see the curves, they're sitting on one another, whereas the right side, you can see the clear separation. ctDNA positive do extremely well, ctDNA negative doesn't do well. Therefore, ctDNA-based prognostication and prediction is better than clinicopathologic distinction. This is stage and MRD detection. What you can notice, only those patients who are in stage 2, 3, only 1/4 of patients would actually require adjuvant therapy. And we can pick it up only by doing the ctDNA. This is the Galaxy study. Again, they looked into ctDNA after surgery. What they said was ctDNA positive, do well, ctDNA negative, do not do well. Very good prognostic implication. This is the 4. So the first one is ctDNA negative, continued to be negative. The second one is ctDNA positive, became negative. The third one is ctDNA positive, became negative, or negative became positive, and the last one is they continued to be positive. Therefore, and if there is liver mets, there is 100% chance of ctDNA positivity. Lung 50%, and peritoneum doesn't shed much of the system of circulation. So therefore, even in a stage 3 disease, if there is MRD negative, giving chemo won't benefit much as per the Galaxy study. The ASCO, the recently discussed ASCO studies also suggested that ctDNA is more prognostic and less predictive, at least in escalation. Escalating with fold-free if ctDNA is positive is not helpful. So learning point number 5. Cell-free DNA is prognostic in colon cancer. It has good predictive value for treatment de-escalation in stage 2, allowing for patients to avoid chemotherapy in 40% of these patients without compromising outcomes. Now coming on to reading an NGS report. So the moment I show an NGS report to you, you will quickly say, okay, let me see the result. Okay, KRAS mutation in lung. All right, this is bone and soft tissue. Uh, this is our right upper lung squamous cell carcinoma, or as mutation there is no drug. So this we cannot do anything about. It's not the way you need to read. What are the how to go about? First of all, you will read the whether what is the material is a paraffin block, right? Limited gene, the limited gene panel of NGS. It is not a it's a focused gene panel. It is not a comprehensive genomic profiling. And then this assay is designed to evaluation of DNA variants, fusion transcripts, targeted 50 gene panel, the Oncomine TM precision assay GX. And then you will see they have looked into SNVs, indels of 45 genes, copy number variations in 14 genes, and fusions from 19 genes, right? This is what they have looked into. And you'll see the tissue, you will see what is the tumor content is 20%. This is the minimum requirement that should be there. Tier 1 is pathogenic, Tier 2 is likely pathogenic. So KRAS and P53. The depth of coverage is this 2908. I will tell you what is depth, and you can see this. This is the limited gene panel. So you have KRAS, Tier 1, and P53, and then there are some fusions, no, and CNVs, none. So let's see what is this Tier 1, 2, 3, 4, 5, 6, and so on. Tier 1, you have a mutation and you have a clinical trial addressing the mutation. Let's say EGFR exon 19 deletion. Yes. Tier 2, alternating drug match associated with antitumor activity, but mind does not need is more prognosis. For example, P53 mutation. Tier 3 is in some other tumor type. For example, I find a PIK3CA mutation in lung. We don't know what to do. So that is Tier 1, 2, 3. What is depth of coverage? If someone asks to read what is this, so how many times will you read? November, Aust. So it is basically number of times the Quran is read. So you have to read at least 5 to 6 times, So the number of times you read this. So what is the depth of coverage? If I read it 100 times, there is a greater chance that I pick up all material. Number of times the Quran is read. Breadth of coverage. So this is the whole statement, Breadth of coverage refers to the scope and comprehensive information including the particular report. So the remaining thing is missing. So I am not reading the whole. This is what is breadth of coverage. So an example. So how is your preparation for exam? Let's say that we have 10 chapters to read for the exam. I have read 6 out of 10 chapters, but I have revised it 20 times. The depth is good, the breadth is bad. I have read all 10 chapters, but only once. Then I have a bad depth, but a good breadth. I have read all 10 chapters and revised it. Very good breadth, very good depth. I have read 6 chapters, but only once. Bad depth, bad depth. Right. So this is what is depth of coverage. So just focus on this bar diagrams. 2x come to the center. These gray bars, the reading happens only twice. So therefore it is 2x. Go to the 4x, come down here. 1, 2, 3, 4. So only 4 times. Similarly here. 1, 2, 3, 4. Similarly, so the number of times a particular codon is read is what is depth of coverage. And what is the breadth? Breadth is the comprehensivity. How much they have read. This is 40% coverage. This is 60% coverage. This is 90% coverage. This is 100. What is WAF? WAF is the proportion of sequence reads that contain a specific field. Means, for example, out of, let's say, if a targeted NGS panel yields 1,000 reads for a particular position and 50 reads are there, then it is 50 by 1,000 into 100 is 5%. Greater the percent, and greater the chance is the driver mutation. So WAF of 3 to 5% is considered actionable, and more than 50 per 30%, you should look for germline mutation. So again, let's see. Let's try and read the NGS report. So here the material is blood. I will say DNA variants, fusion transcripts are read, and then I will look into this as a liver biopsy. The cfDNA is 41%. It's type 2, Tier 2 again. This likely present that is 53 again. Now the mutation, this is liver biopsy in a lung cancer. So I will look into the WAF. It's only 0.8%. Whether is it false negative? Okay, that is the question. Is it false negative? That means there is the lung cancer, but the DNA is not shed. How will you understand that? That is by what is called as tumor fraction. It is the fraction of cell-free DNA that are tumor DNA. Okay, so not all cancers shed. Okay, the cancer have to shed. That is called as the circulating tumor DNA. So if it is high, that means it is representative. If it is low, it is not representative. So what we do is in liquid biopsy, if it is positive, you treat that. If it is negative, there is a possibility of false negativity. For that, you will do, you look for the tumor fraction. If tumor fraction is high, it is representative. It is true negative. It is low, it is a false negative. You do a tissue. So this is a report again suggesting the tumor fraction is 2.1%. Some labs say 10%, some labs do 2%. So this is good tumor fraction, and you can see the TMB is 19.38, and you have a driver mutation. Yeah, ERBP2 is also there. Right, learning point number 6. So review all components of NGS report, including sample, cellularity, type of mutation, discovered, depth, breadth, WAF, and mutation type. Depth, breadth, and WAF are critical for test assessment. Tumor fraction will help determine if the liquid biopsy report is a false negative one or not. Thank you.